Hello, and welcome back to another chapter of Advanced Pathophysiology. Today we're talking about chapter 45, the alterations of the musculoskeletal function. We are stopping, however, at bone tumors today. So, I know my pages do not line up with yours, so just try to keep up as best as possible. So, we'll jump right in. The musculoskeletal system is comprised of bones, muscles, cartilage, tendons, ligaments, and other connective tissues. This system provides structure, support, stability, and movement to the body. Injuries to the musculoskeletal system include fractures, dislocations, sprains, and strains. Additionally, alterations in bones, joints, and muscles may be caused by metabolic disorders, infections, inflammatory or non-inflammatory diseases, or tumors. The most common disease affecting bones is osteoporosis, and the incidence increases with age. Musculoskeletal injuries. Trauma has been termed the neglected disease of modern society. Unintentional traumatic injuries are the number one cause of death for people ages 1 to 44. Fractures are the most commonly caused by falls, car accidents, and athletic injuries. For those who survive traumatic injuries, the impact is significant. Injury affects the families and impacts society because of related loss or limitations of daily activities and mobility, pain, and decreased quality of life. Significant direct care costs are associated with diagnosis and treatment. Indirect care costs are related to time away from work, loss of employment, and decreased productivity. Several national organizations in the United States are collaborating to develop a centralized national resource for injury prevention. Skeletal trauma. Let's talk about fractures. A fracture is a break in the continuity of a bone. A break occurs when force is applied that exceeds the tensile or comprehensive strength of the bone. Fracture incidence varies depending on the bone involved, age, and gender. The highest incidence of fractures occurs in young males ages 15 to 24 and adults 65 years old and older. Rates of hip and wrist fractures tend to be higher in women. An estimated 158 million hip fractures occurred worldwide in 2015. This number is expected to increase to 316 million by 2040. Classification. Fractures are classified as complete or incomplete and open or closed. In a complete fracture, the integrity of the bone is broken into two pieces, whereas in incomplete fracture, the bone is damaged but still in one piece. Complete or incomplete fractures are further classified as open or closed. An open fracture, formerly referred to as a compound fracture, is characterized by a concurrent break in the skin in the area of the fracture. A closed fracture, formerly referred to as a simple fracture, has no break in the surrounding skin. Fractures are classified according to the direction of the fracture line. A linear fracture runs parallel to the long axis of the bone. An oblique fracture is a slanted fracture of the shaft of the bone. A spiral fracture encircles the bone, and a transverse fracture occurs straight across the bone. A fracture in which a bone breaks into more than two fragments is termed a comminuted fracture. So here we're taking a look at different kinds of fractures and different fracture types. So here's a good spot to pause if you're unfamiliar between an oblique, occult, open, pathologic, segmented, spiral, transverse, screen stick, or impacted. The three main types of incomplete fractures are green stick, buckle, or torus, and bowing. A green stick fracture perforates one cortex and splinters the spongy bone, and is relatively unstable. The term green stick is derived from the damage sustained by a young tree branch when it is bent sharply. The outer surface of the bone is disrupted, but the inner surface remains intact. Green stick fractures typically occur in the metaphysis or diaphysis of the tibia, radius, and ulna. In a buckle or torus fracture, the cortex of the bone buckles but does not break, thus making it a relatively stable fracture. Bowing fractures usually occur when longitudinal force is applied to bone. This type of fracture is common in children and is usually involved in the paired radius ulna or fibula tibia. A complete diaphyseal fracture occurs in one bone of the pair, which disperses the stress sufficiently to prevent a complete fracture of the second bone, which bows. Treatment of a bowing fracture is difficult because the bowed bone interferes with the reduction of the fractured bone. In addition, a bowing fracture resists correction, or a reduction, because the force necessary to reduce it must be equal to the force that caused the initial injury. A fracture that results from trauma that would not normally cause a fracture, a low-level trauma, is termed a fragility fracture. Fragility fractures are often a sequela of osteoporosis. Types of fractures are summarized in the following table. Again, a good spot to hit pause and read up on your different types of fractures. So I'll slow down here and I'll go down a little bit and you can pause once more. Fractures may be further classified by cause as pathologic, stress, or transchondral fractures. A pathologic fracture is a break at the site of pre-existing abnormality, usually by force that would not fracture a healthy bone. Any disease process that weakens a bone predisposes the bone to pathologic fracture. This type of fracture is most commonly associated with tumors, infections, osteoporosis, and other metabolic bone disorders. A stress fracture is caused by the cumulative effects of repeated forces over time, such as occurs during athletics. Fatigue and insufficiency fractures are subtypes of stress fractures. Fatigue fractures are caused by abnormal stress or torque applied to a bone with normal ability to deform and recover. Insufficiency fractures include fragility fractures of osteoporosis and osteomalacia and occur in bones lacking normal ability to deform and recover. A transchondral fracture consists of fragmentation and separation of a portion of the articular cartilage that covers the end of a bone at a joint. The fragments may consist of cartilage alone or cartilage and bone. Typical sites of transchondral fractures are the distal femur, the ankle, the kneecap, the elbow, and the wrist. Transchondral fractures are the most prevalent in adolescents. So what is the pathophysiology? When a bone is broken, the periosteum and blood vessels in the cortex, marrow, and surrounding soft tissue are disrupted. Bleeding occurs from the damaged ends of the bone and from the neighboring soft tissue. A hematoma forms within the medullary canal between the fractured ends of the bone and beneath the periosteum. Bone tissue immediately adjacent to the fracture dies. This necrotic tissue and any debris in the fracture area stimulate an intense inflammatory response, characterized by vasodilation, exudation of plasma, and leukocyte and infiltration by inflammatory leukocytes and mast cells. Cytokines, including transforming growth factor beta, platelet-derived growth factor, prostaglandins, and other factors that promote healing, are released. Within 48 hours after the injury, vascular tissue invades the fracture area from the surrounding soft tissue and marrow cavity, and blood flow to the entire bone is increased. Osteoblasts and osteoclasts in the periosteum, endosteum, and marrow are activated to produce subperiosteal procallus, along the outer surface of the shaft and over the broken ends of the bone. Healing generally occurs in three overlapping phases. The initial inflammatory phase of healing lasts 3 to 4 days. During the next few days, the repair phase begins, and capillary ingrowth, together with mononuclear cells and fibroblasts, begins the transformation of a hematoma into granulation tissue. Next, osteoblasts within the procallus synthesize collagen and matrix, which become mineralized to form callus. As the repair process continues, remodeling occurs, during which unnecessary callus is resorbed and trabeculae are formed along the lines of stress. At the end of this stage, bone can withstand normal stresses. The last phase, the remodeling phase, lasts for months to years, except for the liver. Bone is unique among all body tissue in that a fracture it will heal with normal, not scarred tissue. So here we're looking at an exuberant callus formation following a fracture. So what kind of clinical manifestations do we see? Clinical manifestations of a fracture can vary according to the type of fracture, the site of the fracture, and associated soft tissue injury. In general, the signs and symptoms of a fracture include impaired function, unnatural alignment, swelling, muscle spasms, tenderness, pain, and impaired sensation. The position of the bone segments is determined by the pull of attached muscles, gravity, and the direction and magnitude of the force that caused the fracture. One or both segments of the fractured bone may be rotated inward or outward on the bone's long axis, misaligned at an angle, or slide over the segment or out of normal position. Fractures are usually caused by trauma and immediate, often severe pain at the site of injury occurs. Subsequent pain is produced by muscle spasm, overriding of the fracture segments, or damage to adjacent soft tissue. Numbness also is common and caused by swelling, pinching, or severing of a nerve caused by the trauma or bone fragments. Pathologic fractures can cause angular deformity, painless swelling, or generalized bone pain. Stress fractures usually occur in weight-bearing bones. Stress fracture symptoms can vary, but the most common is pain. The pain of a stress fracture is often gradual in onset and can be relieved with rest. Other symptoms of stress fractures include local tenderness and soft tissue swelling. Transchondral fractures may be entirely asymptomatic or painful during movement. Range of motion in the joint is limited, and movement may evoke crepitation, a crunching sensation felt when bones rub against each other. So what is our evaluation and treatment? Treatment of a displaced fracture involves manipulating the bone to realign bone fragments, a reduction, to the correct anatomic position and holding the fragments in place via immobilization so bone healing can occur. Many fractures heal without any kind of manipulation and require only adequate immobilization. Several methods of manipulation are available to reduce a fracture that will not heal with simple immobilization, including closed manipulation, traction, and open reduction. Maligned fractures require the most aggressive treatment of all types of fractures. Fractures can be reduced by closed manipulation if the skin is not opened and the bone is able to be moved or manipulated into place. Appropriate use of closed manipulation occurs when the contour of the bone is well aligned and the alignment can be maintained with immobilization. Traction is another option used to accomplish or maintain reduction of a fracture. When bone fragments are displaced, weights are used to apply firm, steady traction or pull and countertraction to the long axis of the bone. Traction stretches and fatigues muscles that pull the bone fragments out of place, allowing the distal fragments to align with the proximal fragment. Traction can be applied to the skin directly to the involved bone or distal to the involved bone. Skin traction is used when only a few pounds of pulling force are needed to realign the fragments, or when the traction will be used for only a brief time, such as before surgery, or for a few days before applying a cast. In skeletal traction, a pin or wire is drilled through the bone below the fracture site, and a traction bow, rope, and weights are attached to the pin or wire to apply tension by providing the pulling force needed to overcome the muscle spasm and helping realign the fracture fragments. Open reduction is a surgical procedure that exposes the fracture site. The fragments are brought into alignment under direct visualization. Some form of hardware, such as screws, a plate, nail, or wire, is used to maintain the reduction. External fixation is the procedure used to reduce and immobilize significantly displaced open fractures. Pins are placed in the bone proximal and distal to the break, and then stabilized by an external frame of clamps and rods. Bone grafts also are used to repair fractures and filling voids in the bone. These grafts are from the injured individuals, a cadaver, or a bone substitute. So here you're taking a look at an example of external fixation device on a right leg. Improper reduction or immobilization of a fractured bone may result in a non-union, delayed union, or malunion. Non-union is failure of bone ends to grow together. The gap between the broken ends of the bone fills with dense, fibrous, and fibrocartilaginous tissue instead of new bone. Occasionally, the fibrous tissue contains fluid-filled space that resembles a joint, termed a false joint or pseudoarthrosis. Delayed union is union that does not occur until roughly 8 to 9 months after the fracture. And a malunion is the healing of a bone in a non-anatomic position. Treatment of a delayed union and non-union includes use of various modalities designed to stimulate new bone formation. Physical modalities, such as an implantable or external electric current devices, electromagnetic field generations, and low-density ultrasound, have been effective in stimulating bone formation. Stem cells and gene therapy also show promise in promoting formation of new bone. Large defects in bone can be filled with bone grafts or synthetic materials, such as calcium phosphate cement. So here we're taking a look at a non-union of an old fracture. And it looks like it's from the tibia and fibula. So dislocation and subluxation. Dislocation and subluxation are caused by trauma, but also can be caused by ligamentous laxity, nerve injury, rheumatoid disease, or genetic problems. Dislocation is the temporary displacement of a bone from its normal position in a joint. If a dislocation does not involve a fracture, it is a simple dislocation. If there is an associated fracture, it becomes a complex dislocation. If the contact between the two joint surfaces is only partially lost, the injury is called a subluxation. Dislocation and subluxation are the most common in persons younger than 20 years of age and are generally associated with fractures. Dislocation and subluxation, however, may result from congenital or acquired disorders that cause muscular imbalance, as occurs with congenital hip dislocation or neurologic disorders. Incongruities in the articulating surface of the bones, such as with rheumatoid arthritis, or joint instability. Most often, dislocation or subluxated are the joints of the shoulder, elbow, wrist, finger, hip, and knee. The shoulder's glenohumeral joint is a relatively unstable joint because the articular surface of the glenoid cavity is only 1/3 as large as the surface of the humeral head. As a result, the glenohumeral joint is often injured. Physical trauma to the shoulder can cause anterior, posterior, superior, or inferior dislocation. Anterior dislocation is the most common and is usually the result of an indirect force that places the shoulder in extreme external rotation. Posterior dislocations usually occur because of trauma. A superior dislocation is rare and usually the result of an extreme forward and upward force on an adducted arm. Inferior displacement is seen in persons with neurologic injuries of the brachial plexus and is believed to be caused by stretching of the supporting muscles or by joint effusion. So here we see a displaced fracture of a thumb. Traumatic dislocation of the elbow joint is common in the immature skeleton. In adults, however, an elbow dislocation is usually associated with a fracture of the ulna or head of the radius. Posterior dislocation occurs when the individual falls on an outstretched hand with the elbow extended. Anterior dislocations are usually the result of a direct blow to the flexed elbow. Traumatic dislocation of the wrist usually involves the distal ulna or carpal bones. Any one of the 8 carpal bones can be dislocated after an injury. The most common cause is a fall on the hyperextended hand. Dislocation in the hand usually involves the metacarpopharyngeal and interphalangeal joints. Dislocation of the metacarpopharyngeal joint is often the result of a fall on the outstretched hand that forces the joint into hyperextension. Dislocation of the interphalangeal joint occurs because of injury to the fingers in a hyperextended position. Considerable trauma is needed to dislocate the hip. Anterior hip dislocation is rather rare and caused by forced abduction. For example, when an individual lands on his feet from a high fall. Posterior dislocation of the hip can occur in an automobile accident, in which the flexed knee strikes the dashboard. The knee is a relatively unstable joint that depends heavily on the soft tissue structure around it for support. Because the knee is an unstable weight-bearing joint exposed to many different types of motion, flexion, extension, and rotation, it is one of the most commonly injured joints. A knee dislocation can be anterior, posterior, lateral, medial, or rotary. It is often the result of a hyperextension injury that occurs during sports activities. So what is the pathophysiology? Dislocations and subluxations are often accompanied by fractures because stress is placed on areas of bone not normally subjected to stress. In addition, as the bone separates from the joint, it may bruise or tear adjacent nerves, blood vessels, ligaments, supporting structures, and soft tissue. Dislocation of the shoulder may damage the shoulder capsule and the axillary nerve. Damage to the axillary nerve causes anesthesia in the sensory distribution of the nerve and paralysis of the deltoid muscle. Torn periosteum ligaments and muscle frequently accompany elbow dislocations. Bleeding from the damaged periosteum and muscle puts pressure on adjacent arteries that stops circulation to and from the forearm and hand. If the pressure is not completely relieved, ischemic paralysis develops. Dislocation of the hand often results in permanent disabilities because of damage to the tendons and intricate mechanism that allows smooth gliding in the joints. In the hip, avascular necrosis of the femoral head is a complication seen with dislocations. Knee dislocations usually tear both the collateral and the cruciate ligaments. So what kind of clinical manifestations then do we have? Signs and symptoms of dislocations or subluxations include pain, swelling, limitation of motion, and joint deformity. Pain is caused by effusion and inflammatory exudate into the joint or associated tendon, and injury to the ligament. Joint deformity is caused by muscle contraction that exerts pull on the dislocated or subluxated joint or fluid within the joint. Limitation of motion may be a result of a fusion into the joint or the displacement of bones. Tenderness and deformity are prominent in dislocations of the fingers. Unusual muscle pull and pain often result in abnormal posturing of the fingers. For example, the fingers or thumb may be abnormally flexed. A dislocated elbow is often held in a flexed position, and the joint resists activity or passive movement. Pain is a key symptom of shoulder injuries. Attempts to lift the arm aggravate the pain. In most shoulder dislocations, the ability to elevate the arm is minimal, and the individual supports the injured arm with the opposite hand. Pain and an abnormal gait or limp, or inability to bear full weight, usually accompanies traumatic dislocation of the hip. The pain is constant and severe and is felt in the inguinal region or thigh. The thigh and leg may assume a position of inward rotation, adduction, or flexion and appear shortened. In a rare anterior dislocation, the limb is not shortened and the joint is fixed in abduction, outward rotation, and flexion. So our evaluation and treatment. Evaluation of dislocations and subluxations is based on clinical manifestations and röntgenograms. Treatment consists of reduction and immobilization for 2 to 6 weeks and exercises to maintain normal range of motion in the joint. Depending on the joint, healing is usually complete within months to years. So your support structure trauma. Tendon and ligament injuries can accompany fractures and dislocations. A tendon is fibrous connective tissue that attaches skeletal muscle to bone. A ligament is a band of fibrous connective tissue that connects bones where they meet at the joint. Tendons and ligaments support the bones and joints and either facilitate or limit motion. Tendons and ligaments can be torn, ruptured, or completely separated from the bone at their point of attachment. A tear in a tendon is known as a strain. Major trauma can tear or rupture a tendon at any site of the body. Most often injured are the tendons of the hands and feet, the knee, the upper arm, the thigh, the ankle, and the heel. Lifting excessive weight with the arms can cause traumatic rupture of the bicep tendon. Rupture of the Achilles tendon occurs when forced dorsiflexion is applied to the foot when it is in a plantar flexion. Spontaneous tendon ruptures can occur in individuals receiving local corticosteroid injections or fluoroquinolones and in persons with rheumatoid arthritis or systemic lupus, erythematosus. Ligament tears are known as sprains. Ligament tears and ruptures can occur at any joint, but are most common in the wrist, ankle, elbow, and knee joints. A complete separation of a tendon or ligament from its bony attachment site is known as an avulsion. An avulsion is the result of abnormal stress on the ligament or tendon and is commonly seen in young athletes, especially sprinters, hurdlers, and runners. Strains and sprains are classified as first degree, the least severe, second degree, and third degree, the most severe. So what is the pathophysiology? When a tendon or ligament is torn, an extensive inflammatory cascade process begins. Inflammatory mediators, including your cytokines, your nitric oxide, prostaglandins, and lipoxins. An inflammatory exudate develops between the torn ends. Later, granulation tissue containing macrophages, fibroblasts, and capillary buds grow inward from the surrounding soft tissue and cartilage to begin the repair process. Within 3 to 4 days after the injury, collagen formation begins. At first, collagen formation is random and disorganized. As the collagen fibers interweave and connect with the pre-existing tendon fibers, they organize parallel to the lines of stress. Eventually, vascular fibrous tissue fuses the new and surrounding tissue into a single mass. As reorganization takes place, the healing tendon or ligament separates from the surrounding soft tissue. Usually, a healing tendon or ligament lacks sufficient strength to withstand strong pull for 4 to 5 weeks after an injury. If strong muscle pull does occur during this time, the tendon or ligament ends may separate again, which causes the tendon or ligament to heal in a lengthened shape with an excessive amount of scar tissue that renders the tendon or ligament functionless. Scar remodeling may take months to years before it is complete. So, our clinical manifestations, how our patient would present. Tendon and ligament injuries are painful and cause functional limitations. These injuries are usually accompanied by soft tissue swelling, changes in tendon or ligament contour, and dislocation or subluxation of bones. The pain is generally sharp and localized, and tenderness persists over the distribution of the tendon or ligament. Painful joint swelling usually can be seen in fingers and elbow sprains. Flexion deformities of the fingers and thumb occur in injuries to the extensor tendons. Crepitus may accompany tendon injury in the wrist. Tendon or ligament pain in the elbow is accentuated by flexion, supination, and extension of the elbow, or by extension of the wrist. Lifting small objects requires extension of the wrist and therefore aggravates the pain. Tendon injuries in the upper arm cause weakness when the individual tries to flex the forearm. Pain is often the key symptom of shoulder injuries, with pain radiating to the deltoid muscle or extending down the arm, and is aggravated by attempts to actively raise the arm. Depending on the ligament or tendon involved, injuries to the knee may produce pronounced immobility, absence of lateral movement, instability when walking downstairs, flexion deformity, crepitus, or an upward or downward shift of the patella. Your evaluation and treatment, therefore. Evaluation is based on clinical manifestations. Stress radiography, arthroscopy, and arthrography. When possible, treatment consists of protection of the involved structures. So, splinting, promotion of early motion, and rehabilitation. Surgical intervention that sutures the tendon or ligament ends in close approximation may be necessary to treat complete rupture. If this is not possible because of the extent of damage, tendon or ligament grafting may be necessary. Prolonged rehabilitation exercises help ensure that the individual regains nearly normal function. So, tendinopathy and bursitis, trauma, and overuse injuries can cause painful degradation of collagen fibers. So, your tendinosis, inflammation of the tendons, tendinitis, or inflammation in bursal sacs, bursitis. The term tendinopathy includes tendinitis, tendinosis, and peritendinitis. Studies have shown that vascular ingrowth in tendinopathy is accompanied with nerve ingrowth, facilitating pain transmission in Achilles and patellar tendinopathies. Other causes of tendinopathy include crystal deposits, postural misalignment, and hypermobility in a joint. The following table summarizes classes of tendinopathies. So here is a good spot to hit pause and review your anatomy in this sense. Your epicondylitis is inflammation of a tendon where it attaches to a bone. Most tendon pathology, however, is caused by tissue degeneration rather than inflammation. Epicondylar areas of the humerus, radius, or ulna, and the area around the knee are most often involved. Lateral epicondylopathy, commonly called tennis elbow, is the result of tissue degeneration or irritation of the extensor carpi radialis, brevis tendon at its origin. Medial epicondylopathy, referred to as golfer's elbow, is a degenerative process of the pronator teres, flexor carpi radialis, and palmaris longus tendons at the medial humeral condyle. Epicondylopathy is also related to smoking, obesity, and work activities that involve forceful or repetitive cyclic flexion and extension of the elbow, or cyclic pronation, supination, extension, and flexion of the wrist that generates loads to the elbow and forearm region. So here you see tendinitis and epicondylitis. Again, a good spot to pause just to review the muscle groups and tendons. Bursae are small sacs lined with synovial membrane and filled with synovial fluid. They are located between tendons, muscles, and bony prominences. Their primary function is to separate, lubricate, and cushion these structures. When irritated or injured, these sacs become inflamed and swell. Because most bursae lie outside joints, joint movement is rarely compromised with bursitis. Acute bursitis occurs primarily in the middle years and is often caused by trauma. Repetitive irritation can cause chronic bursitis. Septic bursitis is caused by wound infection or bacterial infection of the skin overlying the bursae. Bursitis commonly occurs in the shoulder, hip, knee, and elbow. So what kind of pathophysiology would we see? In tendinitis, inflammatory fluid accumulates, causing swelling of the tendon and enclosing sheath. Inflammatory changes cause thickening of the sheath, which limits movement and causes pain. Microtears cause bleeding, edema, and pain in the involved tendons or surrounding structures. At times, after repeated inflammations, calcium may be deposited in the tendon origin area, causing a calcific tendinitis. The typical bursitis is an inflammation that is reactive to overuse or excessive pressure. The inflamed bursal sac becomes engorged, and the inflammation can spread to adjacent tissues. The inflammation may decrease with rest, heat, and aspiration of the fluid. So what kind of clinical manifestations would we see? Tendinopathy may be asymptomatic, but generally there is localized pain that worsens with active more than passive motion. With symptomatic tendinopathy, the pain is localized over the involved tendon and movement in the affected joint is limited. In bursitis, onset of pain may be gradual or sudden, but movement of the joint itself is normal. Shoulder bursitis impairs arm abduction because the pain and swelling of the bursa. Bursitis in the knee produces pain when climbing stairs, and crossing the legs is painful in bursitis of the hip. Lying on the side of an inflamed trochanteric bursa is also very painful. The following table summarizes common sites of bursitis. Signs of infectious bursitis may include the presence of a puncture site, prior corticosteroid injection, severe inflammation, or an adjacent source of infection. So again, here are some common sites of bursitis and common causes. So again, a good spot to hit pause just to kind of give it a once over. Your evaluation and treatment. Evaluation of tendinopathy, epicondylopathy, and bursitis is based on clinical manifestations, physical examination, arthroscopy, arthrography, ultrasound, and possible MRI. Treatment includes administration of systemic analgesics, application of ice or heat, or local injection of an anesthetic and a corticosteroid to reduce the inflammation. Bursitis may require aspiration to drain the excess fluid. Physical therapy to prevent loss of function begins after acute symptoms have subsided. That leads us to a muscle strain. Mild injury, such as muscle strain, is usually seen with traumatic or sports injuries. Muscle strain is a general term for local muscle damage. It is often the result of sudden, forced motion, causing the muscle to become stretched beyond the normal capacity. Strains often involve the tendon as well. Muscles are ruptured more often than tendons in young people. The opposite is true in older adults. Muscle strain may be chronic when the muscle is repeatedly stretched beyond its usual capacity. There is evidence of tissue disruption with subsequent signs of muscle regeneration and connective tissue repair when a biopsy is performed. Hemorrhage into the surrounding tissue and signs of inflammation also may be present. Knife and gunshot wounds also cause traumatic rupture. Regardless of the cause of the trauma, muscle cells usually can regenerate. Regeneration may take up to 6 weeks, and the affected muscles should be protected during that time. Types of muscle strain, together with their manifestations and treatment, are summarized in the following table. So, there are different degrees of muscle strain. Your first degree, second degree, and third degree. The manifestations include muscle overstretched painfully, the muscle is intact with some tearing pain, mild bruising, fascia is intact, and finally, caused by tearing of fascia. The muscle rupture palpable and bleeding is present. So for first degrees, ice should be applied 5 to 6 times for the first 24 to 48 hours, and complete rest for 2 to 3 weeks, followed by weight bearing 3 times per week and range of motion daily. Second degree, treatment similar to that of first degree strains with added mild analgesics, cryokinetics, and then for third degree, surgery to approximate ruptured edges, immobilization and rest for 6 weeks, followed by an individualized rehabilitation regimen of strengthening exercises. A late complication of localized injury to the muscle is abnormal bone formation in soft tissue, often called myositis ossificans or heterotopic ossification. Its exact physiology remains unknown, but the basic problem seems to be the inability of mesenchymal cells to differentiate into osteoblastic stem cells and the improper development of fibroblasts into bone-forming cells. Though uncommon, heterotopic ossification is associated with burns, joint surgery, and trauma to the musculoskeletal system, or central nervous system. Heterotopic ossification may involve muscle or tendon, ligaments, or bones near the muscle. An example includes the rider's bone, in which the adductor muscle of the thigh of equestrians becomes calcified, as well as in football players after muscle injury to thigh muscles, and a drill bone, in which the same complication is seen in the deltoid and pectoral muscles of fencers and infantry soldiers. So that leads us to rhabdomyolysis. Once used interchangeably with the term myoglobinuria, rhabdomyolysis is the rapid breakdown of muscles that causes the release of intracellular contents, including protein pigment, myoglobin, into the extracellular space and bloodstream. Physical interruption in the sarcolemmal membrane, called delta lesions, suggests that the sarcolemmal membrane is the route through which muscle constituents are released. Myoglobinuria, first described in victims of crush injuries in London during World War II, refers to the presence of the muscle protein myoglobin in the urine. Most recently, myoglobinuria has been reported in individuals found unresponsive and immobile for long periods, such as drug and alcohol overdoses. So our pathophysiology. Rhabdomyolysis is sometimes incorrectly used interchangeably with crush injury, compartment syndrome, or crush syndrome. Although relatively rare, rhabdomyolysis has many causes and can result in serious complications including hyperkalemia, metabolic acidosis, acute renal failure, and even disseminating intravascular coagulation. Even the weight of extremely, a limp extremity can generate enough pressure to produce muscle ischemia. So the following box here are selected causes of rhabdomyolysis. So here's a good spot to hit pause and kind of review different risks. So here's a good spot to pause. And I'll pause here so you can pause one more time. And then under traumatic. There are a lot of causes, so try not to go too quickly so you don't miss out on any of them. Again, that pause button is our friend. And that should conclude that. So here there is the pathogenesis of compartment syndrome and crush syndrome. Again, it's nice to see the difference of how it works. So it's a good spot to hit pause and kind of give it a review. Malignant hyperthermia, or MH, is a potentially life-threatening hereditary disorder of skeletal muscle ryanodine receptors, or that RYR1, allowing large quantities of calcium to be released from the sarcoplasmic reticulum, SR, after exposure to certain volatile anesthetics. The sustained elevation of calcium concentration allows excessive stimulation of aerobic and anaerobic glycolytic metabolism, causing a hypermetabolic state resulting in respiratory and metabolic acidosis, muscle rigidity, altered cell permeability, and hyperkalemia. Dantrolene, a skeletal muscle relaxant, inhibits calcium release from the sarcoplasmic reticulum and is used to reverse the effects of malignant hyperthermia. Compartment syndrome occurs when blood flow to the affected area is compromised because of increased venous pressure, leading to decreased arterial inflow, ischemia, and edema. Emergency treatment may be required to save the affected limb. Classic symptoms of compartment syndrome are pain out of proportion to the injury, paresthesia, pallor, pulselessness, and paralysis. Of these symptoms, pain is the most sensitive clinical sign. When clinical evaluation is inconclusive, the rising compartment pressure can be directly measured by inserting a Vick catheter, needle, or slit catheter into the muscle. Immediate fasciotomy and debridement are advocated for reducing elevated intracompartmental pressures. Those frequently affected are the compartments of the leg, the volar compartment of the hand, the abdomen, and the gluteal compartments. So clinical manifestations. A classical triad of muscle pain, weakness, and dark urine is considered typical of rhabdomyolysis. But those affected may have no complaint of pain or muscle weakness. Abnormally dark urine caused by myoglobinuria may be the first and only symptom. The renal threshold for myoglobin is low, so only 200 grams of muscle needs to be damaged to cause visible changes in the urine. Myoglobin is rapidly cleared, and levels may return to normal within 24 hours of injury. Along with the release of myoglobin, creatine kinase and other serum enzymes are released in massive quantities. The efflux of proteins and enzymes also include the loss of potassium, phosphate, nucleotides, creatinine, and creatine. Serum hypocalcemia is seen early in the course of myoglobinuria and is followed by late hypercalcemia. So, what is the evaluation and treatment? The most important and clinical manifestation or and useful measurement in rhabdomyolysis is serum creatinine kinase level. With normal CK serum levels of 5 to 25 units per liter for women and 5 to 35 units per liter for men, a level 5 times the upper limit of normal is used to identify rhabdomyolysis. Once CK levels exceed 5,000 units, acute renal failure is likely. A recent study evaluated the ultrasonographic appearance of rhabdomyolysis in damaged muscle from earthquake victims and found abnormalities in muscle texture and subcutaneous tissue, as well as areas of liquid in the damaged tissue. Maintaining adequate urinary flow and prevention of kidney failure are primary goals of treatment. Rapid IV hydration maintains adequate kidney flow. Other issues, such as hyperkalemia, may require temporary hemodialysis. Other treatments, such as using mannitol to cause an osmotic diuresis or bicarbonate to alkalinize the urine, have not been shown to be consistently improvements of outcome. So not the way to go. Disorders of bones. Metabolic bone disorders. Metabolic bone disease is characterized by abnormal bone structure that is caused by altered or inadequate biochemical reaction, resulting in disorders of bone strength. Abnormalities include genetic, mineral, vitamin, hormone, pardon me, and structural abnormalities. Osteoporosis. Osteoporosis, or porous bone, is the most common bone disease in humans. It is characterized by low bone mineral density, impaired structural integrity of the bone, decreased bone strength, and risk of fractures. Those with the lowest BMD, or bone mineral density, are at the most risk of fracture. There are two types of osteoporosis: primary or idiopathic osteoporosis. Which is the most common? The secondary osteoporosis. Secondary osteoporosis is caused by other conditions, including an endocrine disease, medication, and other substances. Other conditions, including rheumatoid disease, HIV, malignancies, malabsorption syndromes, liver or kidney disease, also increase the risk for developing osteoporosis. Cortical bone becomes more porous and thinner, making bones weaker and prone to fractures. According to the WHO, has defined osteoporosis on the basis of bone density. So here are some risk factors for osteoporosis. Again, good spots to pause if you're unfamiliar with osteoporosis. If you're looking at the cause, you can kind of also see how you would then treat it, theoretically. And here we're looking at a porous bone, the vertebral body, the osteoporotic vertebra. So, normal bone mass is greater than 833 milligrams per centimeter square. Osteopenia, or decreased bone mass, is 833 to 648 milligrams per centimeter squared. And osteoporosis is bone mass less than 648 milligrams per centimeter squared. Osteoporosis is a complex, multifactorial chronic disease that often progresses silently for decades until a fracture occurs. It is the most common disease that affects bone. It is not necessary or not necessarily a consequence of the aging process because some older adults retain strong, relatively dense bones. In osteoporosis, old bone is being reabsorbed faster than new bone is being made, causing the bones to lose density, becoming thinner and more porous. A progressive loss of bone mass may continue until the skeleton is no longer strong enough to support itself. Eventually, bones can fracture spontaneously. As bone becomes more fragile, fractures occur from falls or bumps that would not previously have caused a fracture. Severe or established osteoporosis is identified when there has been a fragility fracture. The disease can be generalized, involving major portions of the axial skeleton, or regional, involving one segment of the appendicular skeleton. Throughout a lifetime, old bone is removed and new bone is added to the skeleton. During childhood and teenage years, new bone is added faster than old bone is removed. Consequently, bones become larger, heavier, and denser. Bone formation continues at a pace faster than resorption until peak bone mass, or maximum bone density and strength, is reached around age 30, after which bone resorption slowly exceeds bone formation. In women, bone loss begins before menopause and is most rapidly in the first years after menopause, but persists throughout the postmenopausal years. Osteoporosis is most common in women at a rate of 1 to 2 women. Men are also at risk, with an estimated 1 in 4 men experiencing an osteoporosis-related fracture at some point in one's lifetime. In adults older than the age of 50, the prevalence of osteoporosis at either the spine or the femoral neck by age ranges from 3 to 10% in men and 7 to 35% in women. One study showed that in men, the prevalence of osteoporosis did not increase with age until age 80 years or older, but in women, it increased for each decade after age 50. Roughly 52 million people in the US are affected by osteoporosis or low bone density. The major risk for persons with osteoporosis are fractures. Men lose bone density with aging, but because they begin with a higher bone density, they reach osteoporotic levels at an older age than do women. In 2011, state the US Preventive Service Task Force issued a recommendation that women aged 65 and older should be routinely screened for osteoporosis. Hip fractures, in particular, can be devastating effects on an individual's life. In addition to direct medical costs, studies have shown decreased quality of life as well as excessive loss of life years for those experiencing hip or osteoporotic fractures. Vertebral fractures are the most common osteoporotic fracture, but may be asymptomatic. Even if the fracture does not cause pain, vertebral fractures can cause deformity, reduced pulmonary function, and loss of height. The degree of compression necessary to define a vertebral fracture has not been standardized. Osteoporosis affects all races and both sexes. Recent data from the National Health and Nutritional Examination Survey showed that Mexican Americans had higher risk for osteoporosis, whereas non-Hispanic Black persons had lower risk of osteopenia or osteoporosis at the lumbar spine or femoral neck. Multiple genetic factors also influence development of osteoporosis. Whites are more susceptible than other races to osteoporosis, caused by loss of bone density with age. Blacks have only about half the fracture found in whites, probably related to the higher peak bone mass, but Black women remain at a high risk because of factors such as decreased dietary calcium intake, a high percentage of lactose intolerance, and increased prevalence of disease. such as sickle cell disease and lupus, that increase the risk of developing osteoporosis. Both black women and black men have generally been undertreated for osteoporosis. Decreased bone strength with aging is partly due to lower bone mass, but other factors, such as deterioration of type 1 collagen, likely contribute to increased fracture risk. Measuring bone mineral density by using a dual X-ray absorptiometry continues to be the most common method of estimating bone mass. Bone quality relates just to bone mass, but also to the microarchitecture of the bone. Other variables include crystal size and shape, brittleness, vitality of bone cells, structure of bone proteins, water volume, integrity of the trabecular network, vascular supply, and the ability to repair tiny cracks. Because bone density relates to quantity of bone, bone quality is not accurately identified by bone density testing. Therefore, bone density testing may or may not accurately identify individuals with increased fracture risk. An online tool called Fracture Risk Assessment incorporates clinical risk factors with BMD at the femoral neck to predict an individual's 10-year probability of fracture. This tool is available here at this website. So if you want to hit pause and take a look at that website, you are welcome to. Postmenopausal osteoporosis occurs in middle-aged and older women. It can occur because of estrogen deficiency, as well as estrogen-independent age-related mechanisms. Recent studies indicate that increased oxidative stress and increased intracellular reactive oxygen species play a significant role in the development of age-related bone loss, as well as other age-related changes in the body. Hormonal deficiency also can increase with stress, excessive exercise, and low body weight. Postmenopausal changes include a substantial increase in bone turnover, that is, an imbalance between the remodeling activity of osteoclasts and osteoblasts. Increased formation and longevity of osteoclasts results in increased bone resorption and is associated with a cascade of pro-inflammatory cytokines. Increased cytokine activation, especially tumor necrosis factor, can occur with declining estrogen levels. In addition, estrogen helps protect against the effects of OS and osteoclast apoptosis. Biologically, these processes involve the receptor activator of nuclear factor K-beta ligand, or the RANKL, transcription factors such as the forkhead proteins, and WNT and osteoproteagenerin signaling pathways, and insulin-like growth factor. Other causes may include a combination of inadequate dietary calcium intake and lack of vitamin D, possibly decreased magnesium level, lack of exercise, low body mass, and family history. IGF is known to help in fracture healing and collagen synthesis and improves conditions for bone mineralization. IGF levels significantly decline by age 60, however. The level of sex hormones, especially estradiol and testosterone, are significant in premenopausal bone maintenance. However, when estrogen levels drop after menopause, it appears that circulating androgens become significant effectors on bone metabolism. In clinical studies of women, data have suggested that serum androgens influence bone density in pre, peri, and postmenopausal women. Androgens have long been recognized to stimulate bone formation. Other risk factors are identified in box 45.2. Poor nutrition and insufficient intake or malabsorption of dietary minerals, particularly calcium, are factors in the development of osteoporosis. Calcium absorption from the intestines decreases with age, and studies of individuals with osteoporosis show that their calcium intake is lower than that of age-matched controls. Deficiencies of vitamins, particularly vitamin C, D, E, and K, also contribute to bone loss. Skeletal homeostasis depends on a very narrow range of plasma calcium and phosphate concentrations, which are maintained by the endocrine system. Therefore, endocrine dysfunction ultimately can cause metabolic bone disease. In addition to declining levels of sex steroids, the hormones most commonly associated with osteoporosis are parathyroid hormone, cortisol, thyroid hormone, and growth hormone. Excessive intakes of caffeine, alcohol, and nicotine, along with low body fat, have been considered risk factors. In addition, significant differences in the levels of trace elements were noted in the bones and hair of unaffected individuals compared with those with osteoporosis. The development of selective estrogen receptors modulators for the treatment of postmenopausal osteoporosis increases bone formation and builds more muscle mass. In theory, selectively affecting bone, muscle mass, and other desired sites while not affecting lipid or estrogen levels or blood pressure. Side effects can be controlled, but since the direct effects of your selective estrogen receptor modulators on bone are not yet known, this remains a clinical challenge. Secondary osteoporosis sometimes develops temporarily in individuals receiving large doses of heparin, perhaps because heparin promotes bone resorption by decreasing collagen synthesis or by increasing collagen breakdown. Osteoporosis caused by heparin therapy usually resolves when therapy ceases. Treatment with other medications may lead to development of osteoporosis, such as the use of glucocorticoids treatment. For many chronic diseases, processes, other medications that increase the risk of osteoporosis include lithium, methotrexate, anticonvulsants, cyclophosphamide, and cyclosporins. One secondary cause, transient osteoporosis of the hip, is associated with a third trimester of pregnancy, or the immediate postpartum period. However, most transient osteoporosis is a typical self-limiting syndrome affecting the lower extremity joints of middle-aged men. The etiology is unknown, and although most cases spontaneously resolve, some occurrences of bone demineralization may be related to osteonecrosis. Regional osteoporosis. Osteoporosis confined to a region or segment of the appendicular skeleton, usually has a known cause. Transient regional osteoporosis has no known etiology, is characterized by bone marrow edema, and causes severe pain. The lower extremity is most often affected, but other areas also may be involved. Fortunately, it is usually self-limited. It tends to occur in middle-aged men and women in their late second or third trimester of pregnancy. I'm a little confused about how middle-aged men are in their second or third trimester of pregnancy, but let's push past that. It is characterized by bone marrow edema, seen on an MRI, and areas of localized bone demineralization are seen on plain radiographs. Treatment is primarily symptomatic, and the condition usually resolves spontaneously over 3 to 6 months with no long-term adverse effects. Classic regional osteoporosis is associated with disuse or immobilization of a limb because of fractures, motor paralysis, or bone or joint inflammation. A negative calcium balance develops early and continues throughout the period of immobilization. After 8 weeks of immobilization, significant Osteoporosis is present, although it may develop earlier in persons younger than 20 years of age or older than 50 years. A uniform distribution of osteoporosis has been observed in astronauts and in individuals treated with air suspension therapy as a result of weightlessness or lack of mechanical strength. The pathophysiology. Whatever the cause, osteoporosis develops when the remodeling cycle, the process of bone resorption and bone formation, is disrupted, leading to an imbalance in the coupling process. The explosion of new information in the field of bone biology has led to new understanding of roles of hormones, growth and signaling factors, and cellular biology in osteoporosis. Although hormonal influences remain important in maintaining bone health, genetic factors and the role of oxidative stress are receiving increased attention as critical determinants of bone homeostasis. Reactive oxygen species are normal byproducts of aerobic metabolism, and although they can cause cell damage at, at levels below which they cause oxidative stress, reactive oxygen species serve as signaling molecules for many cell types, including your osteocyte, osteoblast, and osteoclast. When excessive reactive oxygen species, or ROS, accumulate, your oxidative stress, or OS, occurs and can result in loss of bone mass and bone strength. The osteoclast's differentiation pathway is directed by a series of processes that include proliferation, differentiation, fusion, and activation. These processes are controlled by hormones, cytokines, and paracrine stromal cell microenvironment interactions. Thus, the intercellular communication in bone and the key molecular regulators are necessary for bone homeostasis. Certain transcription factors, known as the forkhead box, help protect against the effects of OS by preventing excessive accumulation of ROS and regulating certain genes that affect DNA repair and cell lifespan. FOXOS helps remove damaged and abnormal cells by inducing apoptosis. Your interleukins 1, 4, 6, 7, 11, and 17, tumor necrosis factor alpha, transforming growth factor beta, prostaglandin E2, and hormones interact to control osteoclasts. Normal bone homeostasis is dependent on the balance between the cytokine receptor activator and the nuclear factor Kupffer beta ligand, the rankle, and receptor rank, and its decoy receptor, osteoprotegerin. Understanding this has led to the tremendously increased knowledge of osteoclast biology and pathogenesis of bone loss. So here is a good spot to hit pause so you can see the skeletal system, stromal cells or osteoblasts, and how they work in our system. Here you have the OPG, the rankle and rank system, receptors, activators of nuclear factor K beta ligand. So if you're unfamiliar with how this system works, or if you want a visual aspect of how the system works, good spot to hit pause. Rankle, a member of the TNF family, is expressed by osteoblasts and their immature precursors, and is necessary for osteoclast development. Rankle activates the receptor rank, which is expressed on osteoclasts and their precursors, and suppresses apoptosis, which leads to activation and prolongation of osteoclast survival. The effects of rankle are blocked by OPG, a glycoprotein that acts as a decoy receptor of rankle that prevents it from binding and activating rank. Cytokines and hormones regulate the balance between rankle and OPG. Alterations of the rankle-rank OPG system can lead to a dysregulation and pathologic conditions, including osteoporosis, immune-mediated bone diseases, malignant bone disorders, and inherited skeletal diseases. Postmenopausal osteoporosis is characterized by increased bone resorption relative to the rate of bone formation, leading to sustained bone loss resulting from estrogen deficiency. Bone loss resulting from estrogen deficiency also contributes to osteoporosis in men. Increased bone resorption results from enhanced development of osteoclasts and decreased osteoclast apoptosis. Estrogen stimulates OPG secretion and downregulates rankle. Drugs known as selective estrogen response modifiers, or SERMs, also stimulate OPG production. In estrogen deficiency, the exact role of OPG is less clear. Postmenopausal women express higher levels of rankle on bone marrow stromal cells, your T cells, and B cells, than premenopausal women. Importantly, rankle expression is increased when estrogen levels are decreased, leading to increased formation of osteoclasts, while reducing osteoclast apoptosis. Other factors, such as sclerostin or SOST, a glycoprotein secreted by osteocytes, are powerful inhibitors of osteoblast formation by binding to low-density lipoproteins, receptor-related protein 5, and prevent binding with frizzled protein and WNT signaling. Important factors in osteoblast and bone formation. Sex steroids exert anti-apoptotic effects on osteoblasts, but exert pro-apoptotic effects on osteoclasts. In both scenarios, this is accomplished by activating the extracellular signal-regulated kinases. Estrogen activates ERKs, or extracellular signaling regulating kinases, outside the nucleus. ERKs then accumulate in the nucleus and activate downstream transcription factors. This confusing and complicated information eventually revealed that the important determinant of whether pro-apoptosis or anti-apoptosis was exhibited was the length of time that the phosphorylated ERKs remained in the nucleus. Prolonged nuclear accumulation of activated ERKs converted the anti-apoptotic effect of estradiol to pro-apoptotic. In addition to ERKs, rankle promotes the anti-apoptotic effect of osteoclasts, thus increasing their lifespan. WNT signaling induces a biochemical series of events that increases osteoblasts and bone formation. Alterations in WNT signaling account for critical pathophysiologic changes in most acquired metabolic bone diseases, including postmenopausal osteoporosis, aging effects, and glucocorticoid excess. Agents such as parathyroid hormone and biphosphonates used for treatment of bone loss exert their positive effects by altering the formation of osteoblasts or osteoclasts, or by inducing osteoclast apoptosis. Glucocorticoid-induced osteoporosis is characterized by increasing bone resorption and decreased bone formation. Glucocorticoids increase rankle expression and inhibit OPG production by osteoblasts. The use of immunosuppressive drugs to reduce rejection of transplanted organs also alters the OPG rankle-rank system and can lead to post-transplantation osteoporosis. Other conditions affected by the OPG rankle-rank include rheumatoid arthritis, myeloma, vascular disease, and skeletal metastases from neoplastic disorders. Age-related bone loss begins in the third to fourth decade. The cause remains unclear, but it is known that decreased serum growth hormone and IGF levels, along with increased binding of the rankle and decreased OPG affect osteoblast and osteoclast function. Loss of trabecular bone in men proceeds in a linear fashion, with thinning of trabecular bone rather than complete loss, as is noted in women. Men have roughly 30% more bone mass than women, which may be the factor in their later involvement with osteoporosis. Androgens promote osteoprotegerin production, thus inhibiting the osteoclastic effects of rankle. Reduction in physical activity in older persons also may be a major factor in the degree of bone loss, because preservation of bone mass depends on skeletal stress through muscle contraction and weight bearing. So here you see different levels of osteoporosis. And here's the mechanism of loss of trabecular bone in women and trabecular thinning in men. So, what are our clinical manifestations? The specific clinical manifestations of osteoporosis depends on the bones involved. The most common manifestation, however, is bone deformity. Pain tends to occur only when there is fragility fracture. Fractures are likely to occur because the trabeculae of spongy bone become thin and sparse, and compact bones become porous. As the bone loses volume, they become brittle and weak and may collapse or become misshapen. Vertebral collapse causes kyphosis or hunchback and diminished height. Fractures of the long bones, distal radius, ribs, and vertebrae are most common. The most serious fractures associated with osteoporosis are hip fractures because of their resultant chronic pain, disability, diminished quality of life, and premature death. Fracture of the neck of the femur tends to occur in older women with osteoporosis. Fatal complications of fractures include fat or pulmonary embolism, hemorrhage, and shock. Roughly 20% of people with a hip fracture die as a result of a surgical complication. So here we have some severe kyphosis. Evaluation and treatment, therefore. Generally, osteoporosis is detected radiographically, as is increased radiolucency of bone. By the time abnormalities are detected by X-ray exam, as much as 25 to 30% of bone tissue may have been lost. Types of radiologic examinations include single or dual photon absorptiometry and CT scans. Because osteoporosis is asymptomatic unless a fracture occurs, diagnosis is often delayed. At present, your DXA is the current examination of choice for diagnosis. Unfortunately, DXA does not provide information about the bone strength or fracture risk. Bone density is based on the number of standard deviations that differ from the mean bone mineral density of a young adult reference population. Osteopenia is categorized as a bone density score between 1.5 and 2.5 standard deviations below normal. A t-score of 2.5 or more standard deviation below normal bone density is considered osteoporosis. Severe or established osteoporosis is defined when there has been a fragility fracture associated with low density in the bone. The disease can be generalized as involving major portions of the axial skeleton or regional loss that involves one segment of the appendicular skeleton. So here you have your T-score classification. If you want to give that a quick once over, it does not, a quick once over to give it a look. It does not hurt to know this. Because fractures are the primary complication of osteoporosis, the WHO has developed an assessment tool to estimate an individual's 10-year risk of fracture. The WHO Fracture Risk Assessment is a downloadable computer draft questionnaire that has been developed for use in Europe, North America, Asia, and Australia. Once completed, the embedded algorithm predicts a 10-year probability of hip, spine, forearm, or shoulder fracture. This tool can be loaded from this following website. Other evaluations procedures include tests for level serum of calcium, phosphorus, and alkaline phosphatase, as well as protein electrophoresis. Body calcium levels also can be measured by neuron activation analysis, a procedure involving use of radioactive calcium-49, whose gamma activity can be measured with a whole body counter. Though prevention of osteoporosis is paramount, treatment is more common and is focused on preventing fractures and maintaining optimal bone function. The role of calcium intake to prevent and treat osteoporosis is controversial. It is well accepted that oral calcium intake sufficient to maintain normal calcium balance is necessary during adolescence to ensure development of peak bone mass, and that calcium deficient diets can aggravate bone loss associated with menopause and aging. Although recommendations have been established for young women of 1 gram of calcium daily and for postmenopausal women of 1500 milligrams daily, it has been difficult to translate these recommendations into a clear-cut clinical outcome. A significant relationship has been observed between the individual's lifetime history of calcium intake and peak bone mineral density. Diets with higher fruit and vegetable intake seem to correlate with a higher BMD. Other nutrients that appear to have a positive impact on bone health include magnesium, vitamin K, and docosahexaenoic acid, or DHA. So here is a small section on the nutrition and disease. If you wish to read this, go ahead and hit pause. Magnesium, another mineral important for skeletal development, is an essential mineral in many biochemical and physiologic functions, including the activation of enzymes, involvement in adenosine triphosphate, or ATP synthesis, and protein synthesis, regulation of membrane channels, and contraction of muscle. Magnesium is important to bone quality because it helps control hydroxyapatite crystal growth and thereby prevents formation of brittle bones. It seems reasonable that magnesium is required for normal calcium absorption because severe magnesium deficiency results in hypocalcemia. Regular moderate weight-bearing exercises can slow the rate of bone loss and, in some cases, reverse demineralization because the mechanical stress of exercise stimulates bone formation. It is important to reduce the risk of falls and enhance bone quality. Therefore, an exercise program to enhance muscle strength is advised. Important new findings suggest that estrogen may prevent excessive bone loss before and after menopause by limiting osteoclast lifespan through promotion of apoptosis. SERMs are being used to provide the positive effects of estrogen on bone, but minimize estrogen's negative effect on breast and endometrial tissue. As a result, in addition to reducing vertebral fractures, SERMs reduce risk of estrogen receptor breast cancer and improve lipid profiles. Raloxifene and tamoxifen are examples of SERMs. Biphosphonates are a class of inorganic pyrophosphate derivatives that bind bone mineral and improve osteoblast and osteocyte survival, while promoting osteoclast apoptosis. thus slowing the bone remodeling process. Nitrogen-containing biphosphonates are highly effective in reducing both vertebral and non-vertebral osteoporotic fractures. Because of this, biphosphonates are the mainstay of osteoporosis treatment. Side effects include alterations in TGF-beta signaling that may cause osteonecrosis of the jaw. There also is a small risk of atypical femoral fractures, AFib, and possible esophageal cancer associated with biphosphonates. The optimal length of treatment with biphosphonates has not yet been determined. One of the most promising treatments for osteoporosis is denosumab, a monoclonal antibody that binds the cytokine receptor activator and nuclear factor K beta ligand, RANKL. RANKL inhibition blocks the maturation, function, and survival of osteoclasts, thus reducing bone resorption. Teriparatide, also called PTH-134, is a biosynthetic form of parathyroid or parathormone and contains the first 34 amino acids of parathyroid hormone. PTH-184 is a recombinant PTH that contains all 84 amino acids of naturally occurring PTH. Both work by stimulating osteoblasts when administered intermittently, given by subcutaneous injection. PTH reduces vertebral fractures, but use is limited to a period of 24 months because of the risk of developing osteosarcoma. A recent large meta-analysis of osteoporosis treatment found improved BMD and reduced fractures with biphosphonates, SERMs, and denosumab, though each regimen has potential adverse effects. Restoration of a balanced RANKL-OPG ratio or inhibition of RANKL responsiveness is known to prevent osteoclast activation and bone resorption. Anti-RANKL therapy significantly reduces bone resorption. Other biologic agents under investigation include cathepsin K inhibitors, anti-sclerostin, and anti-Dickopf antibodies that affect the WNT beta-catenin signaling pathway in osteoblasts. So that was quite a bit just for osteoporosis. But it leads us to osteomalacia. Osteomalacia is a metabolic disease characterized by inadequate and delayed mineralization of osteoid in mature, compact, and spongy bone. In osteomalacia, the remodeling cycle proceeds normally through osteoid formation, but mineral calcification does not occur. Bone volume remains unchanged, but replaced bone consists of soft osteoid instead of rigid bone. The result is abnormal bone matrix mineralization. Rickets is similar to osteomalacia in pathogenesis, but occurs in growing bones of children, whereas osteomalacia occurs in adult bone. Chronically low serum phosphate levels can be caused by tumors, resulting in osteomalacia. Fibroblast growth factor 23 plays a significant role in maintaining normal serum phosphate levels, primarily produced by osteocytes. FGF23 functions to inhibit reabsorption of phosphate in the renal proximal tubule. Osteomalacia and rickets are rare in the US and parts of Europe, but are significant health problems in Great Britain, Ethiopia, Pakistan, Iran, and India. In the US, these diseases occur in older adults, in premature infants of a very low birth weight, and in individuals adhering to rigid macrobiotic vegetarian diets. Breastfed black infants who do not receive vitamin D supplementation have been shown to be at risk of developing nutritional rickets. Many factors contribute to the development of osteomalacia, but the most important is a deficiency of vitamin D. The major causes of Vitamin D deficiency are diets deficient in vitamin D, decreased endogenous production of vitamin D, intestinal malabsorption of vitamin D, renal tubular diseases, and anticonvulsant therapy. Classic vitamin D deficiency is rare in the US because of the addition of synthetic vitamin D to dairy products and bread. Still, disorders of the small bowel, kidney, hepatobiliary system, and pancreas do not or do cause vitamin D deficiency in the US. In malabsorptive disease of the small bowel, vitamin D and calcium absorption are decreased, so vitamin D is lost in feces. Liver disease interferes with the metabolism of vitamin D to its more active form, and diseases of the pancreas and biliary system cause a deficiency of bile salts, which are necessary for normal intestinal absorption of vitamin D. The mechanism by which anticonvulsant drug therapy results in decreased bone mineral density is not completely understood, but appears to be from direct impact on bone or effects on other regulators of bone metabolism, such as calcium, vitamin D, and parathyroid hormone. The anticonvulsants phenobarbital and phenytoin interfere with calcium absorption and increase degradation of vitamin D metabolism in the liver through activation of the cytochrome P450 pathway. So what is the pathophysiology? Crystallization of minerals in osteoid require adequate concentration of calcium and phosphate. When the concentrations are too low, crystallization, and hence ossification, does not proceed normally. Vitamin D deficiency disrupts mineralization because vitamin D normally regulates and enhances the absorption of calcium ions from the intestines. A lack of vitamin D causes the plasma calcium concentration to fall. Low plasma calcium levels stimulate increased synthesis and secretion of parathyroid hormone. Although the increase in the level of circulating PTH rises and raises the plasma calcium concentration, it also stimulates increased renal clearance of phosphate. When the concentration of phosphate in the bone decreases below a critical level, mineralization cannot proceed normally. Abnormalities in the spongy as well as compact bone, trabeculae in the spongy bone become thinner and fewer, whereas Avulsion systems in compact bone develop large channels and become irregular. Because osteoid continues to be produced but not mineralized, abnormal quantities of osteoid accumulate, coating the trabeculae and the lining of the Avulsion canals. Excessive osteoid also can accumulate in areas beneath the periosteum. The excess of osteoid leads to gross deformities of the long bones, spine, pelvis, and skull. So our clinical manifestation. Osteomalacia causes varying degrees of diffuse skeletal pain and tenderness. Bone pain is typically between joints rather than within them. Pain is not particularly in the hips, and the individual may be hesitant to walk. Muscular weakness, particularly of the proximal muscles, is common and may contribute to a waddling gait. Facial deformities and bowed knees or knock knees may be present. Bone fractures and vertebral collapse occur within minimal trauma. Low back pain may be an early complaint, but pain also involves ribs, feet, and other areas of the vertebral column and other sites. Uremia may be present in renal osteodystrophy. So our evaluation and treatment, therefore. Lab data may include elevated BUN, or blood urea nitrogen, and creatinine levels, normal or low serum calcium levels, and serum inorganic phosphate level that is usually higher than 5.5. Alkaline phosphatase and PTH levels are usually elevated. Radiographic findings show pseudofractures and radiolucent bands perpendicular to the surface of involved bones. Bone biopsy is useful in determining bone structure and remodeling. Diagnosis of certain types of osteomalacia is becoming easier, because of the ability to measure an individual's serum FGF23 level. Elevated FGF23 levels are common in X-linked hydrophosphatemic and tumor-induced osteomalacia. Treatment includes the following: adjusting serum calcium and phosphorus levels back to normal, suppressing secondary hyperthyroidism, chelating bone aluminum if needed, administering calcium carbonate to decrease hyperphosphatemia, adding dietary supplements of vitamin D, performing renal dialysis, and considering a renal transplant for renal osteodystrophy. That takes us to Paget's disease. Paget's disease of bone is a state of increased metabolic activity in bone, characterized by abnormal and excessive bone resorption and formation. Genetic manipulation involving the Rankel NFK beta signaling pathways are significant in the development of Paget's disease, resulting in increased osteoclast activity. Chronic accelerated remodeling eventually enlarges and softens the affected bone. Classic Paget's disease arises as a consequence of a disorderly bone resorption and formation. Paget's disease most often affects the axial skeletal, or skeleton rather, especially the vertebra, skull, sacrum, sternum, pelvis, and femur. The disease process may occur in one or more bones, causing significant clinical manifestations. The disease is seldom found before age 40, but its incidence almost doubles each decade from age 50. It affects men more than women in a proportion of 1.8 to 1. Because it is often symptomless and can be diagnosed only by invasive procedures, few epidemiologic data is available. Autopsy data from England and Germany indicate that approximately 3 to 4% of people older than 40 have Paget's disease. It is most prevalent in Australia, Great Britain, New Zealand, and in the US. The cause of Paget's disease is unknown. However, studies have implicated both genetic and environmental factors. About 10 to 30% of individuals with Paget's have mutations of a specific gene, sequestrosome 1. Even viral etiologies have been proposed. So what is the pathophysiology? Well, Paget's disease begins with excessive resorption of spongy bone and deposition of disorganized bone. The trabeculae diminish, and bone marrow is replaced with extremely vascular fibrous tissue. The resorption phase of Paget's disease is followed by the formation of abnormal new bone at an accelerated rate. The collagen fibers are disorganized and glycoprotein levels in the matrix decrease. Mineralization may extend into the bone marrow. Bone formation is excessive around partially resorbed trabeculae, causing them to thicken and enlarge. Eventually, Paget disease progresses to an inactive phase, in which abnormal remodeling is minimal or absent. Osteoclasts of individuals with Paget's disease have increased response to rankle. So your clinical manifestations. In the skull, abnormal remodeling is first evident in the frontal or occipital regions and then encroaches on the outer and inner surfaces of the entire skull. The skull thickens and assumes an asymmetrical shape. Thickened segments of the skull may compress areas of the brain, producing altered mentality and dementia. Impingement of new bone on cranial nerves causes sensory abnormalities, impaired motor function, deafness, atrophy of the optic nerve, and obstruction of the lacrimal duct. Headache is commonly noted. So here you're taking a look at Paget's disease of the skull. Extensive alterations of the facial bone are rare, except in the jaw. Rare sclerosis and thickening of the maxilla and mandible displace teeth and produce malocclusions. In long bones, resorption begins in the subchondral region, and the epiphysis and of the epiphysis and extends into the metaphysis and diaphysis. Warmth over the affected area, bone and joint pain, and bone deformity may occur. Occasionally, Paget's disease affects both ends of a long bone. In the femur, Paget's produces an exaggerated lateral curvature. In the tibia, anterior curvature is also exaggerated. Stress fractures are common in the lower extremities. Clinical manifestations of Paget's in the vertebral column depend on the level of involvement and are caused by compression of adjacent structures. In the cervical spine, cord compression can lead to spastic quadriplegia. Roughly 1% of people with Paget's develops osteogenic sarcoma. Paget-related sarcoma has a poor prognosis, unfortunately. So our evaluation and treatment. Evaluation of Paget is made on the basis of radiographic findings of irregular bone trabeculae with a thickened and disorganized pattern. A typical V-shaped lesion in long bones and rounded areas of thinning bone in the skull are often seen on plain X-rays. Bone scanning can more readily detect early disease as well as extent of Paget through increased uptake of bone radionuclides. Serum total alkaline phosphatase and urinary hydroxyproline levels are elevated. Most individuals require no treatment because the disease is localized and does not cause symptoms. Treatment during active disease for the pain relief, prevention of deformity, or fracture by phosphonates and calcitonin are the mainstays of treatment. Surgery is indicated if there are no neurologic complications or severe bone deformities. That leads us to our last section here, infectious bone disease, our osteomyelitis. Osteomyelitis is a bone infection, most often caused by bacteria. However, fungi, mycobacteria, parasites, and viruses also can infect bone. Exogenous osteomyelitis is an infection that enters from outside the bone, for example, through open fractures, penetrating wounds, or surgical procedures. In exogenous osteomyelitis, infection spreads from soft tissue into adjacent bone. Endogenous osteomyelitis is caused by pathogens carried in the blood from sites of infection elsewhere in the body. In hematogenous osteomyelitis, infection spreads from the bone to adjacent soft tissue. Hematogenous osteomyelitis is commonly found in infants, children, and older adults. In infants, incidence rates among males and females are approximately equal. In children and older adults, however, males are more commonly affected. Osteomyelitis is a common complication of sickle cell anemia and low oxygen tension. So here's a picture of osteomyelitis. So Staphylococcus aureus is a primary cause of hematogenous osteomyelitis. Other microorganisms include group B streptococci, Haemophilus influenza, Salmonella, and gram-negative bacteria. Group B streptococci and H. influenza tend to infect young children. Salmonella infection is associated with sickle cell anemia, and gram-negative infections are most common in older adults and individuals with an impaired immunity. Mycobacterial and fungal infections occur in immunocompromised individuals. Cutaneous, sinus, ear, and dental infections are the primary source of bacteria in hematogenous bone infections. Soft tissue infections, disorders of the gastrointestinal tract, infections of the gastrourinary system, and respiratory tract infections are also sources of bacterial contamination. In addition, infections contracted after total joint replacement surgeries can be caused or can be causes of osteomyelitis. The vulnerability of a specific bone depends on the anatomy of its vascular supply. In adults, hematogenous osteomyelitis is more common in the spine, pelvis, and small bones. Microorganisms reach the vertebra through arteries, veins, or lymphatic vessels. The spread of infection from the pelvic organs to the vertebra is well documented. Vaginal, uterine, ovarian, bladder, and intestinal infections can lead to iliac and sacral osteomyelitis. Exogenous osteomyelitis can be caused by human bites or fist blows to the mouth. Superficial animal or human bites inoculate local soft tissue with bacteria that later spread to underlying bone. Deep bites can introduce microorganisms directly onto bone. The most common infecting organism in human bites is S. aureus. In animal bites, the most common infecting organism is Pasteurella multocida, which is part of the normal mouth flora of cats and dogs. Direct contamination of bones with bacteria also can occur in open fractures or dislocations with an overlying skin wound. Intervertebral disc surgery and operative procedures involving implantation of large foreign objects, such as metallic plates or artificial joints, are associated with exogenous osteomyelitis. Local injections and venous punctures are significant causes of exogenous osteomyelitis. Exogenous osteomyelitis of the arm and hand bones tends to occur in drug abusers. S. aureus is the most common pathogen. In general, people who are chronically ill, have diabetes or alcoholism, or are receiving large doses of corticosteroids or immunosuppressive drugs are particularly susceptible to exogenous osteomyelitis or recurring episodes of this disease. So, our pathophysiology. Regardless of the source of the pathogen, the pathologic features of the bone infection are similar to those in any other body tissue. First, the invading pathogen provokes an intense inflammatory response. Inflammation in bone is characterized by vascular engorgement, edema, leukocyte activity, small blood vessel thrombosis, and abscess formation. Once inflammation is initiated, the small terminal vessel thromboses and exudate seals the bone's canaliculi. Inflammatory exudate extends into the metaphysis and the marrow cavity and through small metaphyseal openings into the cortex. In children, exudate that reaches the outer surface of the cortex forms abscesses that lift the periosteum off underlying bone. Lifting off the periosteum disrupts blood vessels that enter bone through the periosteum, which deprives underlying bone of its blood supply. This leads to necrosis and death of the area of bone infected, producing sequestrum, an area of devitalized bone. Lifting of the periosteum also stimulates an intense osteoblastic response. Osteoblasts lay down new bone that can partially or completely surround the infected bone. This layer of new bone surrounding the infected bone is called an involucrum. Opening in the involucrum allows the exudate to escape into surrounding soft tissue and ultimately through the skin by way of sinus tracts. Involucrum in adults is rare because the periosteum is firmly attached to the cortex and resists displacement. Instead, infection disrupts and weakens the cortex, which predisposes the bone to pathologic fractures. So our clinical manifestations. Clinical manifestations of osteomyelitis vary with the age of the individual, site of involvement, initiating event, infecting organism, and whether the infection is acute, subacute, or chronic. Acute osteomyelitis causes an abrupt onset of inflammation. If an acute infection is not completely eliminated, the disease may become subacute or chronic. In subacute osteomyelitis, signs and symptoms are usually vague. In the chronic stage, infection is indolent or silent between exacerbations. The microorganisms persist in small abscesses or fragments of necrotic bone and produce occasional flare-ups of acute osteomyelitis. The progression from acute to subacute osteomyelitis may be the result of inadequate or inappropriate therapy, or the development of drug-resistant microorganisms. In the adult, hematogenous osteomyelitis has an insidious onset. The symptoms are usually vague and include fever, malaise, anorexia, and weight loss. Recent infection or instrumentation usually precedes the onset of symptoms. Back pain is the primary symptom in vertebral osteomyelitis. Pain may be intermittent or constant, aggravated by motion and throbbing at rest. It may radiate in a radicular distribution and is commonly accompanied by spinal tenderness and rigidity. Hip contracture can occur in the presence of soft tissue inflammation as a result of irritation of the psoas muscle. Signs and symptoms of the sacroiliac osteomyelitis are generally severe and include local pain, tenderness, and a limp. The pain may radiate to the buttocks or the abdomen. Single or multiple abscesses characterize subacute or chronic osteomyelitis. Brody abscesses are painless, circumscribed lesions of 1 to 4 centimeters in diameter, usually in the ends of long bones, and surrounded by dense ossified bone matrix. The abscesses are thought to develop when the infectious microorganism has become less virulent, or the individual's immune system is resisting the infection somewhat successfully. In exogenous osteomyelitis, signs and symptoms of soft tissue infection predominate. Inflammatory exudate in the soft tissue disrupts muscles and supporting structures and forms abscesses. Low-grade fever, lymphedema, local pain, and swelling usually occur within days of contamination by a puncture wound. Osteomyelitis in the hand causes exquisite tenderness over the course of tendon sheaths. The fingers are usually in a semi-flexed position, and extension usually causes severe pain. Palmar swelling or symmetrical swelling of the fingers may be present. So lastly, evaluation and treatment. Lab data shows an elevated white blood cell count. Radiographic studies include radionuclide bone scanning, CT, and MRI. MRI is especially useful in detecting early bone changes associated with infection. Infectious bone disease is expensive and difficult to treat and often culminates in extensive physical disability. The following factors contribute to the difficulty in treating bone infection. Bone contains multiple microscopic channels that are impermeable to the cells and the biochemicals of the bone's natural defenses. Once bacteria gain access to these channels, they are able to proliferate unimpeded. The microcirculation of bone is highly vulnerable to damage and destruction of bacterial toxins. Vessel damage causes local thrombosis of the small vessels, which leads to ischemic necrosis of bone. Bone cells have a limited capacity to replace bone destroyed by infection. Initially, osteoclasts are stimulated by infection to resorb bone, which opens up isolated bone channels so that cells of the inflammatory and immune system can gain access to the infected bone. At the same time, however, resorption weakens the structural integrity of the bone. New bone formation usually lags behind resorption, and the Avulsion system in the new bone are incomplete. Treatment of osteomyelitis includes surgical debridement with bone biopsy and culture before or as soon after initiating antibiotics as possible. Initial antibiotic therapy should be intravenous. Chronic conditions may require surgical removal of the inflammatory exudate, followed by continuous wound irrigation with antibiotic solutions in addition to systemic treatment with antibiotics. Hyperbaric oxygen therapy of 100% oxygen given at 2 atmospheres of pressure for 2 hours duration per day for 30 treatments is also beneficial for chronic refractory osteomyelitis. Implanted hardware may require removal to more thoroughly treat an infected joint. And that completes our chapter here today. We're not jumping any further than this. So I will see you in the next chapter, chapter 47, the structure, function, and disorders of the integument. I'll see you all then. Thanks again for watching, and goodbye.